My name is Lauren Lindeman, and I'm a dietetic intern at UTMB in Galveston, and this is a PowerPoint presentation about nutrition support for acute pancreatitis in severe and critical patients. At the end of this presentation, you should be able to describe the prevalence, etiology, and diagnosis of severe acute pancreatitis. Discuss the effects of severe acute pancreatitis on length of stay and mortality. Determine nutrition's role in supporting metabolism of patients with severe acute pancreatitis. Conclude the best possible nutrition support recommendations using evidence-based research and determine areas of study that would benefit from continued research. And you'll be able to define the RD's role in prevention of malnutrition, malabsorption, and poor hospital outcomes in these patients. So the topics of discussion will be prevalence in the U.S., etiology, signs and symptoms, diagnosis, determining severity, pancreatic metabolism, metabolic needs, causes of increased mortality, factors affecting length of stay, and then we'll look at the current nutrition recommendations and also some research that suggests the difference between enteral and parenteral nutrition in severe pancreatitis, the use of NG tubes versus NJ tubes in severe acute pancreatitis, early or delayed enteral nutrition, and we'll also look at some new research in supplements added to enteral nutrition, including prebiotics, probiotics, and symbiotics. We'll look at when TPN is indicated, clinical implications for practice for the dietitian, some future research in areas in need of continuing research, and references. How prevalent is it in the U.S.? Well, it is the leading GI cause of hospitalization. It affects 270,000 people annually, and it increases 5% per year, not only in the U.S. but also in Europe. And as you can see, even from 1998 to 2002, it greatly increased. And interestingly enough, 20% of these cases have existing diabetes. Now, that could also be because there's a high prevalence of diabetes in America, but I thought it was very interesting that the main organ that has dysfunction in that disease also had a 20% case of acute pancreatitis in the U.S. So how does this happen and where does it come from? Etiology shows that alcohol intake accounts for 25 to 35% of acute cases. Now, in chronic cases, this is even more prevalent, and most chronic cases have high roots in etiology in alcohol intake. Also, hyperlipidemia, as measured by triglycerides of greater than 1,000 milligrams per deciliter, trauma including surgery in the abdomen or the gut, a recent ERCP. Now this is an endoscopy of the pancreas, and usually it's used to determine if there's a bowel obstruction or a gallstone. And so looking into the pancreas and using an endoscopy just as exploratory can also cause pancreatitis. Medications, including side effects of medications and drugs. Most recently, diabetes medications have been common and have shown that there are side effects of acute pancreatitis. Genetics, so if you have a family history, that can put you at a greater risk for having pancreatitis. And then cholelithiasis, so gallstones, is the most common case, especially in the milder cases of pancreatitis. And the way to predict that, an ALT of greater than 150 units per liter is very highly predictive of gallstones. And then sometimes We just don't really know what happens or where it comes from. It's idiopathic in nature. The study by Nesvatarani is an Australian study, and they actually suggested that it could be due to rising rates of morbid obesity. So, hyperlipidemia, hyperglycemia, metabolic syndrome, diabetes, these are all correlated with morbid obesity. So, it's important to know that this could be a cause, and since our country in America is very similar to Australia and that we have a high rate of morbid obesity, that could be a reason for our cases of acute pancreatitis here. So signs and symptoms, it's important to know when you're interviewing a patient what kinds of symptoms to look for or to note in a chart for a doctor. It's usually associated with abdominal pain, especially after eating, and this pain radiates to the back. So it's not to be confused with kidney stones or other issues like that. It can also be pancreatitis. Also, severe vomiting and diarrhea happens in acute cases. Now, the difference between acute and chronic is usually recurrent flare-ups or cases of pancreatitis, and it's associated with the same upper abdominal pain, but the difference is these patients also experience steatorrhea, which is foul-smelling diarrhea, and it's a very severe case of diarrhea, or unintended weight loss. So this could be really important when you have a patient that you're unable to acquire a very detailed past medical history, or we don't have any records at our hospital because they've been to another hospital or they're from a different state or a different region. It can be really important to know that these symptoms are associated with chronic cases and that their one case in our hospital might not have been their only case. And it will also change the way we practice and recommend different types of feeding. So the way we diagnose is 2 of the 3 following conditions. Epigastric or left quadrant pain, it radiates to the back as we said, and the pain location does not necessarily correlate with severity. Serum amylase or lipase usually greater than 3 times the normal. However, in diabetics, it can be even higher because diabetics have a higher mean lipase level, so their lipase is normally elevated more so than a normal patient would be. And amylase, it's important to note that it's not a good predictor on its own. Lipase is probably the better or best predictor when you're looking at lab values. Other characteristic findings from abdominal imaging, including CT, MRI scans, or ultrasound. So the way we determine severity, there's 3 different categories. There's mild, moderately severe, and severe. Usually mild cases, there's no organ failure. This subsides within a few days, and it's just acute pain. In moderately severe cases, organ failure begins to happen within 48 hours, and there's some fluid collection, maybe some pancreatic necrosis or dying tissue, and some systemic complications. This is usually localized and only in the pancreatic area. However, in severe cases, it's persistent organ failure of greater than 48 hours, and due to sepsis and spread of the inflammation, there can be worsening necrosis and multiple organ failure, and this, like I said, persists over 48 hours. Now, there have been different scoring systems associated with pancreatitis. and in order to establish a good way of diagnosing the severity. And these include the BISAP and Apache scoring systems. Also, you can look at different lab values. So elevated BUN and hematocrit are greatly associated with severe cases. And as you'll see later, it's really important to determine how severe the case is early on in the hospitalization to best determine the route of feeding and to better predict outcomes and improve hospital outcomes and reduce length of stay in these patients. So how prevalent are mild and severe cases? Most cases are mild to moderate, so almost 100%, 70 to 90% of cases, but they resolve within 3 to 5 days. 10 to 20% of cases, however, are severe acute pancreatitis, and these are your patients that are going to be in the ICU. They're going to have a greater level of care, and they're going to need to be watched much closer to prevent worsening complications, especially because the mortality rate is about 30%. So what happens to the pancreas and its metabolism during an acute case of pancreatitis? What happens is trypsin is usually activated by enzymes that are secreted from the pancreas. These go to the intestine and it activates trypsin for protein metabolism. But in acute pancreatitis, this trypsin activation is premature, so it happens early, and there's also a decreased inhibitor, so it's upregulated and it is spreading, and the activation of trypsin is very rampant, and this is what causes a lot of the necrosis, and it injures the digestive enzymes, and it leads to more complications of pancreatitis. So usually the thought was to let the pancreas rest. And in acute cases that are mild, that might be true because they're usually resolved within a couple of days, and there aren't too many complications associated with those cases. However, in more severe cases, it's very detrimental because there's so many risks, including multiple organ failure and systematic inflammation that can be spread through the rest of the body and cause mortality. So it might not be as warranted as we had always thought to let the pancreas rest, because it's not really resting. There's always a consistent basal metabolism, and this leads to continued inflammation and autodigestion of the organ. So during acute cases of pancreatitis, it's a state of hypercatabolism where you have an increased REE or an increased negative nitrogen balance and inflammatory response, and the intestine permeability is compromised because there's all kinds of inflammation spreading, and it can go to other organs, and within the 72 hours it can spread through these intestinal barriers because of the decreased function. So if we let it rest and let it be dormant, it could spread worse than if we were to actually feed it and give it some nutrition. And that's the thought behind the enteral nutrition. Now, this window of 72 hours is also very important to note. So we also need to make sure that we're diagnosing soon enough to determine that it is a severe case and we do need to be on high alert. So these scoring systems also need to be used wisely by the doctors. So metabolic needs during acute pancreatitis, like I said, there's an increased REE because of hypermetabolism, and we need to provide at least 75% of the estimated needs or greater and this is characterized by 25 kcal per kilogram, and usually peptide-based or elemental formulas where the proteins already break down are more preferred for enteral nutrition because the pancreas doesn't have to work to break down that protein. So what causes increased mortality? Things that can come up are cysts or pseudocysts, and that is a direct effect of the pancreas and the way it auto-digests itself or is overly inflamed during an acute case of pancreatitis. Bacterial translocation, so like we said with the intestinal permeability, it is compromised, and so the bacteria in our gut is more likely or more able to spread to different tissues. And necrotic tissue, this is dying tissue of the pancreas because of the autodigestion. Multiple organ dysfunction syndrome, systemic inflammatory response syndrome, increased length of stay, malnutrition, comorbidities, and BMI greater than 30 kilograms per meter squared. So this is really important, as we've seen with malnutrition cases in the past. If someone's already malnourished, they're already at risk for increased length of stay. So if they are in an acute attack of the pancreas and they have an increased length of stay and they were already malnourished, then these two can really affect each other and make that risk of mortality even greater. As well as comorbidities, this goes along with multiple organ dysfunction syndrome. Comorbidities such as renal or heart failure, people are more susceptible to this organ dysfunction, and so they already have some issues present and the organs become more compromised and it only worsens from there. In BMI greater than 30, like we said, we have a high prevalence of obesity in the US, so this is really, it could be really common for our patients to have more risk of mortality. So factors affecting length of stay: age greater than 60 years, comorbidity, fasting time greater than 3 days, intolerance to oral feeding, additional examinations required, which can take more time or cause time to be delayed because certain doctors or radiologists are not present or they have other appointments to go to as well. The severity of acute pancreatitis puts you at a greater risk for an increased length of stay, and it's really important to reduce that because increased length of stay greater than 7 days decreases your nutritional status and puts you at greater risk of malnutrition. So current nutrition recommendations, this is taken from the American Journal of Gastroenterology, and it's their 2013 recommendations. Right now, mild to moderate cases are usually NPO until pain or nausea and vomiting subsides, and they're given aggressive fluids. It's also been shown that within 24 to 48 hours, it's really important to get ample amounts of fluids into these people. However, after 48 hours, there is no benefit with aggressive fluids, and if people have comorbidities such as renal or cardiac disease, they're at greater risk for fluid retention and edema. So it's really important not to fluid overload these people. Elderly are also at greater risk of fluid overload. It can accumulate in their lungs and in their legs and arms, and if they're unable to void it properly, it can become a real problem. So oral refeeding immediately once nausea and vomiting subsides, as well as abdominal pain. And clear liquid and low-fat diets are equally safe in terms of reintroduction. So some studies have shown that you don't necessarily have to start with clear liquids to advance to low-fat diets, but that you could go straight to a low-fat diet after being in PO for so many days. And it was safe and people had good outcomes with these low-fat diets. Low-fat diets are important just to prevent hypertriglyceridemia and complications in the future. Severe cases, usually enteral nutrition can be indicated, and we're going to talk about different types and the timing of that as well. TPN across the board is not preferred generally in acute cases because this can cause a higher risk of bacterial translocation when the gut is dormant and the intestines are already at risk of having a lower permeability. Adding TPN to that can greatly increase your risk for bacterial translocation and sepsis and other complications. The only time it's generally indicated is if enteral nutrition is not tolerated. I've also seen in some studies where TPN and enteral nutrition is used in conjunction, and it seemed, or the study had deemed it appropriate and safe. So that might be something to think about in the future. So when comparing enteral and parenteral feedings, enteral across the board appears to be much better than parenteral. Not only is it less expensive, but it reduces infectious complications and mortality. It decreases organ failure and surgical intervention. It preserves the gut and provides better glycemic control than TPN. It prevents bacterial translocation as well. People have a decreased hospital length of stay when receiving feedings enterally in acute pancreatitis. They also have a greater quality of life and reduced catheter-related infections, and early enteral nutrition within 48 hours to 72 hours may be beneficial. So like we said earlier, when the pancreas is so inflamed, that 72-hour window is really when a lot of the necrotic tissue and the spreading of the infection can happen. And so to prevent that, the theory is to start enteral nutrition as soon as possible. So when looking at different routes of feeding, this meta-analysis had 3 randomized controlled trials, about 157 patients, and 90% of the patients tolerated enteral nutrition via the nasogastric route versus the nasojejunal. But there really wasn't a difference in mortality or nutrition-associated adverse events, incidence of aspiration, which can be a concern with enteral nutrition, diarrhea, or pain exacerbated with refeeding. And both routes restore energy balance, and they've seen, however, that early nasojejunal feeding is associated with decreased mortality, and we're going to look at a study specifically here in a bit, but the theory of the metabolism and why we want the route of the nasojejunal over the nasogastric is because at the ligament of Treats, it bypasses 3 phases of the pancreatic secretion. So this prevents release of trypsin, which was the cause of concern and why the pancreas ends up being inflamed and really infectious. So significant secretions of trypsin and lipase occur in response to elemental formula when delivered into the duodenum over the jejunum in healthy subjects. So the thought is that the nasojejunal route might be better tolerated. However, this is mostly in theory, and some studies have shown it, but we still need more multi-center studies. The only concern really is that nasojejunal routes are difficult to place. It takes a radiologist to ensure that the tube gets to the correct place. So it's going to take more time, more money, and more equipment, as well as more of a team of experts in order to place this tube in correctly. So this study looked at early versus delayed enteral nutrition in the nasojejunal route. And there were 60 patients with diagnosed severe acute pancreatitis, and they used the Apache score as you saw earlier in our diagnosis slide. So they used the NJ tube and they passed the ligament of Treats. They used a peptide-based formula. Continuous feedings were started at 15 to 20 milliliters per hour and increased the same amount every 6 to 8 hours to determine tolerance. The needs that were met were 20 to 25 kcal per kilogram and 1.5 grams per kilogram of protein per day. Now, there's not a certain protein recommendation. However, this is similar to what we usually use at the Methodist Hospital for our protein recommendation, so I thought that was interesting and that it might be a good recommendation to use in the future. And the results were that the earlier enteral nutrition group that was fed within 48 hours of admission had significantly lower multi-organ distress syndrome, systemic inflammation, infection, and shorter ICU stay. And there was no difference in mortality or operation noted in the intervention. And enteral nutrition shows to impact immune regulation in patients with severe acute pancreatitis, producing positive outcomes in prevention of worsening complications. So when looking at pre, pro, and symbiotics, previous studies that had studied patients not necessarily with acute pancreatitis, but they were receiving enteral nutrition, and showed that probiotics enhance the intestinal barrier function, so that reduced permeability is thought to be improved with addition of probiotics. They stimulate production of antimicrobial peptides, prevent bacterial translocation and overgrowth. They protect the intestinal barrier, and pre, pro, and symbiotics have shown to decrease length of stay when added to enteral nutrition. And more importantly, severe acute pancreatitis patients have shown to have decreased flora, antioxidants, and the fiber and nutrients are just wiped out in the gut from not being fed and from all of the inflammation and systemic complications associated with it. So that can also complicate micronutrient metabolism in the future in these patients. So when added with prebiotic fiber supplementation, 30 patients with severe acute pancreatitis who required NPO for at least 48 hours were given isocaloric feedings via an NJ tube. And they had equal distribution of fats, carbs, and protein. And the study group received soluble and insoluble fiber supplementation. Both groups also received support nutrition through parenteral nutrition and a peripheral line. It contained glucose, amino acids, and lipids. And when compared with controls, the study group had improved acute phase response and decreased hospital stay. So they were thinking that prebiotics can improve immune response. When added with symbiotics, which is a probiotic plus a prebiotic, such as a fiber, these patients were given lactobacillus specifically, an oat fiber, and an NJ tube for 1 week. Now, this study is a little bit older. It's from 2002, but many of the studies and the systematic reviews that I had reviewed kept referring to this study. So my thought is this was one of the original studies to start off the interest in probiotics when added to enteral nutrition. in pancreatitis subjects. So what happened is they showed an effective reduction of necrotizing tissue and decreased need for surgical intervention. And few studies to date have researched the similar effects of symbiotics, so I really do hope to see more in the future. If this small study was beneficial, I wonder if it would do the same in larger multi-center studies. So the concern with probiotics is that some studies show that it was beneficial and some show no difference, but this study specifically showed that it was harmful. And when added with Acidophilus, Casei, Salivarius, Lactis, Bifidobacterium, and Bifidolactids, all of these strands together versus a placebo, when given within 72 hours of admission for 28 days, the mortality was significantly increased in the probiotic group. So I kind of wonder, was it the strands that were used? Were there too many used all at once? Or maybe it was just too long of a treatment. We're not really sure. But warnings have been made due to this study and others like it. So the American Journal of Gastroenterology really recommends not to use probiotics as they could be potentially harmful. So, in conclusion, probiotic recommendations have been shown to be promising in animal models and primary clinical trials. However, multi-center trials have been contradictory, and there really isn't a large number of cohorts associated with these trials, so more research and more powered research is really necessary to determine whether this can be put into place for practice or not. Also, so probiotics cannot be indicated for treatment at this time, but however, prebiotics and symbiotics show promising results. So the thing they have in common is the fiber, so maybe fiber is also productive, and I think that research is really needed in this area to determine whether we can recommend it or not. So when TPN is indicated, I know we said that almost all studies said that TPN is really not recommended. Years and years ago, that was all that we could use, or that's all that clinicians thought that was beneficial for pancreatitis patients. However, it's been shown over and over again that it's really not preferred in acute cases because it can increase the harmful effects of the metabolism and leads to malabsorption and malnutrition in the future. However, when there's chronic cases and there's already malabsorption and malnutrition present due to long-term reduced integrity of the pancreas, TPN might be indicated because there might not be any other route that we can really feed these patients. And it's also indicated when enteral nutrition is not tolerated, or when it's not meeting nutritional needs, or when it's not available due to a blocked duct or a tumor or bowel obstruction associated with the pancreas. And I really still wonder if TPN can be supported for enteral nutrition in the future. So clinical implications for practice: usually NPO for 5 to 7 days and TPN alone is not generally recommended. When you get to 5 to 7 days, you are increasing your risk for mortality, length of stay, and further complications. However, enteral nutrition may be indicated within 48 hours in severe cases. So it's really important for us as clinicians to help determine how to diagnose that sooner and how to score and define that severity as soon as possible so that we can determine the best route of nutrition as soon as possible. The nasojejunal route appears to be safe and effective. It bypasses the pancreatic metabolism, but it also preserves gut function, which is optimal for pancreatitis. We also want to provide at least 25 kcal per kilogram, and we want to use elemental or peptide-based formula because these are proteins that have already been broken down, and it won't be hard on the pancreas to break down these proteins even further. And reducing length of stay can potentially prevent further malnutrition complications, hospital return, and exacerbated pancreatitis. Future research is needed in diagnosis, so scoring systems and other methods used to determine severity within 48 hours so that we can use that critical time to best determine the route of feeding. Early enteral nutrition via an NJ tube is definitely needed. More research in that area in order to make sure that that is the best recommendation. We need multi-center trials with larger amounts of cohorts. We also need to determine the best timing for initiation to determine how to best prevent complications early on in the hospitalization. TPN is indicated or could be indicated in conjunction with tube feeding, as we've seen, and I really think that there needs to be more research using both as supportive methods, because then we might be able to get more nutrition via a parenteral line, so we can get more micronutrients or calories or protein in the event that enteral nutrition is not enough or it's not tolerated. However, we also need to use the tube feed and the enteral nutrition for supportive care as well. We also need more research in prebiotics, symbiotics, and probiotics to determine if this is beneficial or not beneficial in subjects with pancreatitis in multi-center studies. The following are the nutrition recommendations for acute pancreatitis from the American Journal of Gastroenterology. So, like we've talked about, in mild acute pancreatitis, oral feedings can be started once there's no nausea or vomiting. In mild acute pancreatitis, initiation of feeding with a solid low-fat diet is just as safe as a clear liquid diet. So we might not have to start with a clear liquid diet and advance to full liquids and advance from there to a low-fat diet. Patients might actually be able to go straight to a solid diet. And in a severe case of acute pancreatitis, enteral nutrition is recommended to prevent infectious complications. However, parenteral nutrition should be avoided unless the enteral route is not available, not tolerated, or not meeting caloric requirements. And I really think there needs to be more evidence in that area just to see if enteral can be supported by parenteral nutrition or not. And the nasogastric delivery and nasojejunal delivery of enteral feeding appear to be comparable and just as safe and the same amount of efficacy in multi-center trials. And I really think we just need more research in the area of the best timing of when to initiate those feedings. These are my references. Thank you very much for listening, and please let me know if there are any comments or questions.